56-year-old male, accountant in Kuwait, with the date of admission on 9/3/2022, with the chief complaints of right-sided weakness and difficulty in speech since 7 days.
So, what all things are possible here?
Mostly it will be CVA, sir. With weakness and difficulty in speech, mostly it will be cerebrovascular accident, sir.
Other possibilities are there other situations where somebody can come with hemiparesis or hemiplegia other than vascular?
Traumatic cause, sir.
Traumatic, yes. Can it be neoplasia?
SDH or EDH?
Possible. Okay.
Yes, sir.
So we have some basic diagnosis acute event. Okay. So this is a history.
History of presenting illness. Patient developed numbness of right side of the body at around 9 a.m. while at work. After 1 hour, he developed difficulty in walking, swaying to the right side of the body, and difficulty in raising his hand above head. Developed difficulty in speech, not able to talk certain words. No history of loss of consciousness, vomiting, fever, head injury. No history of chest pain, breathlessness, or palpitations. He was taken to a nearby hospital where MRI was taken and was started on antiplatelets.
So what do you think about this story?
Sir, it's an acute onset CVA ischemic stroke, sir.
Right.
Mostly left-sided lesion, cortical lesion, sir. Left-sided cortical lesion.
Okay. Numbness of right side of the
numbness. Sir. Numbness and of the right side of the body.
So where is the lesion?
Thalamic lesion, sir.
That's right. And
thalamic lesion.
Swaying to right side of the body and difficulty to raise hand and difficulty to speak.
Yes, sir. Difficulty in speech. Sir, Wernicke's aphasia, sir.
But he is able to talk. He's not
but
able
not.
to talk.
Yes, sir. Not. Okay, sir. Not able to talk certain words, sir. Okay. Nominal aphasia, sir.
Let's go forward. Let us see.
Past history. No history of similar episodes in the past. Patient is diabetic and hypertensive since 4 years and on regular medication. Personal history. Non-vegetarian diet, adequate sleep and appetite, regular bowel and bladder habits. On general examination, patient conscious oriented, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Vitals, pulse of 70 per minute, BP 110/70, respiratory rate of 16, SpO2 98% in room air. Examination of nervous system, higher mental function, is a right-handed person, conscious, oriented to time, place and person, immediate and recent memory is impaired, remote memory is intact, low mood, attention and concentration impaired, no hallucination or delusions. Speech, comprehension is present, fluency is absent, repetition is present, decreased word output.
How do you interpret this part of the story?
Sir, probably conduction aphasia, sir.
Very good, very good. So what type of conduction aphasia is that?
Since fluency absent, other comprehension and repetition is present, conduction aphasia.
Transcortical motor aphasia you mean?
Yes, sir, transcortical motor aphasia, sir.
So his lobes were assessed. So this is the finding.
Okay, sir. Frontal lobe, personality, reserved individual, antisocial behavior absent, attention is impaired, no urinary incontinence, language, fluency absent, word finding difficulties, repetition, naming and writing present, sir.
So, is the bladder affected in frontal lobe lesions?
Mostly frontal lobe lesions will include bladder affection, sir.
In what way?
Ungal lobe, sir.
What type of bladder they will have? What type of bladder problem they will have?
Sir.
Is there a center
Gastric.
in the brain for
Sir?
bladder?
Hello, sir.
Is there a center for bladder in the brain?
Yes, sir.
What does it do?
That inhibition, sir.
So, what type of bladder you will get?
Disinhibited bladder, sir.
A socially uninhibited bladder.
So
Okay, that's fine.
inhibited bladder, sir. Parietal calculation impaired, agnosia, finger agnosia present, apraxia, ideomotor apraxia present, agraphia present, right to left disorientation present.
So, what do you make out of that?
Sir, I forgot that one
Just
syndrome where
Justman
Justman syndrome, sir.
Very good.
Justman syndrome. Parietal non-dominant, spatial orientation is intact, constructional skills are intact, and no anosognosia, sir. Temporal lobe, auditory perception is intact, memory, immediate and recent memory is impaired, smell is intact.
What is apraxia?
Sir, skillful movement, sir.
So somebody knows act, but he is not able
Yes.
to perform. Even
Yes,
if
sir.
he can understand the command.
He is unable to do that, sir.
His motor part is okay, coordination is okay, sensor is okay, but still he is not able to perform.
Yes, sir.
On command, you call it as apraxia. So what is ideal
Yes,
apraxia? What is ideomotor apraxia? How can you test the both?
Okay, sir. Ideomotor, we'll be asking him to do some. No, sir.
That's right. So ideomotor is you ask a patient to use a screwdriver and show how it is done. He must be able to perform.
Okay, sir.
But when you show some objects like toothbrush, he must be able to identify what is it for, and that's the ideal smell.
Okay, sir.
So he had this type of apraxia in this patient.
Okay, sir.
So CNS examination continues.
Cranial nerve 7, angle of mouth deviation to left, loss of nasolabial fold on right side. All other cranial nerve examination was normal. Motor system examination, tone normal on both sides, upper limb and lower limb tone normal on both sides. Power on right side, upper and lower limb has a power of 4/5 with the normal power on left side. Bicep jerks is brisk. On right side, tricep jerk 1 plus, supinator jerk 1 plus, knee jerk brisk, ankle jerk plus, and plantar mute, bilateral plantar mute. With
so
on the
not a hemiparesis.
Yes, sir, hemiparesis, sir.
So now what is your diagnosis now? You have got all the findings now.
Yes, sir. CVA, right-sided hemiparesis,
Right.
with UMN facial palsy.
That's part of hemiparesis, okay.
With UMN facial palsy.
Okay, right.
With the probable involvement of the frontoparietal lobe, sir. Frontoparietal infarct, sir.
That's right. So which vessel is you are postulating?
Sir, vascular pathology, sir.
Vascular pathology. Which blood vessel you are talking about?
Anterior cerebral middle cerebral artery, sir.
Middle cerebral artery you are talking about. Okay.
Yes, sir.
Okay. So where is the Wernicke's area situated?
Area 41, sir.
Which lobe?
Parietal lobe, sir.
Wernicke's area is the posterior part of the superior temporal gyrus. And what about the focus area? Where is it situated?
Wernicke's, sir.
Okay.
Okay.
It's situated in the inferior frontal gyrus.
Okay, so inferior frontal gyrus, sir. Okay, sir.
Fine, good.
Okay, sir. No cerebellar signs. Examination of sensory system. Touch, pain, temperature, vibration, joint position present on both sides. Cortical sensations are absent. No signs of meningeal irritation.
Where do you localize these cortical sensations?
Mm-hmm.
The parietal lobe.
Parietal lobe, sir.
So, what are the cortical sensations you know of?
Tactile localization.
That's right.
Tactile discrimination.
Yes.
2-point discrimination.
Yes.
Stereognosis, sir.
Yes.
Graphesthesia.
And one more. What is meant by sensory inattention? What do you mean by that? What is sensory inattention? When you touch two identical points on two sides, person is not able to say both sides are touched. Is called as sensory inattention.
Okay,
testing these cortical sensations, the primary sensations must be intact.
Yes, sir. Yes, sir.
You select two identical points on left side and right side, test them simultaneously. Yes, patient must be able to say both sides are touched. That is sensory attention.
Yes,
and that is gone, you say sensory inattention.
Okay, sir.
Other system examination were normal in this case. So,
okay, sir.
What's your provisional diagnosis now?
Provisional diagnosis of severe right hemiparesis with human palsy, left human palsy, with probably etiology, vascular etiology involving MCA, medicerebral artery, involving the frontoparietal area, sir. Right sided frontoparietal area, left sided frontoparietal area.
So you thought it is a medicerebral artery occlusion?
Yes,
possibly sir. Thrombotic stroke.
Yes, sir.
Thrombotic stroke. So what investigations you plan in this case?
First of all, you have to go with the routine investigations, yes, blood routine investigations.
Okay.
Followed by imaging, sir.
That's
imaging
right.
modalities. CT brain, first rule out whether it is a hemorrhage. Then if you have to go for MRI, sir.
So hemorrhage was ruled out and MRI was done.
Yes, sir.
And what did you get?
MRI brain with MRI of neck and cerebral vessels shows acute to subacute infarct involving left corona radiata, capsuloganglionic region, insular cortex, thalamus and crus of midbrain. MRI of neck vessels shows complete occlusion of the M2 and M3 segments of left MCA and few collaterals noted.
So this is what you find in the corona radiata.
Okay,
and
sir.
This is capsuloganglionic region.
Okay, sir.
And this is insular
cortex.
And this is the crux of the
midbrain, sir.
And this thalamus also is affected.
Yes, sir.
So this situation can explain most of your findings.
Yes, sir.
Okay. So what your final diagnosis will be?
Cerebrovascular accident, left-sided, MCA territory involvement, thrombotic stroke involving the left capsuloganglionic, thalamic and insular cortex and core of midbrain, sir.
So what's the blood supply of midbrain? Is it medicerebral artery or?
Medicerebral artery, sir.
Midbrain. or is it a posterior circulatory territory?
Posterior cerebral artery.
Okay, but our observation on investigation is only middle cerebral artery. So how do you
Yes, sir.
explain that? Possibility it can be an aberrant blood vessel supplying that area,
Okay, sir.
or there can be, when multiple vessels are affected, you always think about embolism also, but there
Okay,
is
sir.
no evidence of embolism in this case.
Okay, sir.
Okay, so
Okay, sir.
tell them something about this transcortical sensory aphasia.
Transcortical sensory aphasia, the repetition,
The fluency is there,
fluency is there, but repetition,
relatively preserved repetition, but poor comprehension.
poor comprehension, sir. Okay, sir.
Comprehension is poor, but repetition is there. What is
Okay, sir.
transcortical motor aphasia?
Where the comprehension will be normal, repetition normal, but fluency will be absent, sir.
Fluency will be absent.
Yes, sir.
So it's something like Broca's aphasia only,
Yes,
but
sir.
does not classically affect the Broca's area, but some area just above, superior or anteriorly to the Broca's area.
Okay, sir.
Anterior or superior to Broca's area is the area involved in these cases, the dominant
Yes, sir.
hemisphere.
Yes, sir.
What about Wernicke's aphasia? What is it?
Wernicke's aphasia, the comprehension will be lost, sir.
Is it a fluent or a non-fluent aphasia?
Non-fluent aphasia, sir.
Okay. So, what is meant by apraxia? You already mentioned. What is meant by apraxia? Okay. So, what is the management of this patient?
Patient should be started on antiplatelets and statins, sir. Also physiotherapy and speech therapy should be followed, sir.
Okay. This particular patient had agnosia.
Okay,
What is
sir.
agnosia? Finger agnosia. No, here.
Skill.
Okay, what is it? Agnosia. Agnosia is a situation where you are unable to recognize and
Okay, sir.
identify objects, persons,
Okay, sir.
or sounds.
Okay, sir.
Maybe their face, whatever it is. So that is called as agnosia.
Agnosia. Okay, sir.
So this patient had actually Gerstmann syndrome.
Yes, adjustment syndrome, sir.
He had classical loss of these cortical sensations, and
Okay,
he
sir.
had hemiparesis.
Okay, sir.
So clinically a good case in the sense that so many things are there to correlate.
Okay, sir.
Okay, any doubt about this case?
No, sir.
What may be the risk factor for this patient?
Maybe diabetic and hypertensive, sir.
Hypertension.
So-
is the candidate
so,
for accelerated atherosclerosis.
Yes, sir. Metabolic syndrome, accelerated atherosclerosis may be caused, sir.
So such a case, what specifically lost in the history?
Sir, previous episodes of TAA, sir.
Yeah, that's good. TIA must be asked for.
Asked, sir.
Okay.